Welcome to City Radio. My name is Molly Hoops. We are pleased to be with you again from Radio on Fire Studios in Baltimore City on 25th Street. My co-host Tim Mercer happens to be here as well as usual. Tim, thank you.
Thank you, Molly. Thank you.
We have a really important guest today, Dr. Susan Sherman, who is Professor of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. So her time is extremely valuable. We're going to try.
Her time is extremely valuable.
Susan, so welcome, and let's get to it. We want to talk with you about the work that you do at Hopkins, about the issues in Baltimore City that you happen to be on the front lines of, and I guess the first question, just to situate us, is who you are, where you're from, maybe what you do on a regular basis, but briefly.
I go to a lot of meetings, as my little kids say. Like, how many meetings did you have today, Mommy? While you were trying to save the world, being a thinking doctor. That's what distinguishes me from the pediatrician in the mind of a 7-year-old. So I am a professor in the School of Public Health who my work really is at the intersection of social and behavioral science and kind of observational research, evaluating interventions, and then legislative advocacy. And my work focuses on the life and well-being of people who use drugs and women engaged in sex work, many of whom cisgendered women that we work with, who sell sex, 90% of whom use drugs. And I kind of came into this work after having lived in San Francisco in the early 90s, working in the world of AIDS caregiving, and then really interested in how and why diseases kind of fall along the fault lines of a society, and discovered the world of harm reduction, which is kind of sane drug policies and working with people who use drugs where they are. Needle exchange is the best known example of harm reduction. Fell into that, was interested around and really working with women in HIV. That took me to the world of harm reduction because so much of their HIV risk is related to drug use. That was when I was in North Carolina and then in Baltimore, and so I kind of haven't stopped working in that world. So you can ask questions about any of that.
So you go to Annapolis to testify fairly regularly?
Well, when they're in session 3 months a year, I've testified. I helped develop the evidence to change the Baltimore City needle exchange policy was strict 1-for-1 to a distribution model, which is more better evidence of reducing HIV transmission and HIV risk behaviors, for example. So Baltimore City needle exchange is funded by the state every year. The reappropriations, it has to be reapproved, and so for policies to be changed about the needle exchange, it needs to go through the state. So that was one of the first things I helped do research to show that in fact 1-for-1 people didn't have enough coverage for the injections that they were doing daily through the syringes that they were getting from the needle exchange, and there's a lot of evidence to show that it's better for people to be able to get what they need rather than what they can bring back. People can't bring back syringes for lots of different reasons. They may not be able to carry them. They may be afraid to carry them. I mean, most people bring back what they exchange, but if you can't, you shouldn't be penalized, and that's a law that changed 5 years ago. Needle exchange is now legal throughout the state of Maryland, and we helped work on a committee, a really interesting interdisciplinary committee that provided evidence why it was important to scale up syringe services programs, as they're now called, throughout the state to abate the HIV, hepatitis C, and opioid epidemic. And there are a lot more people talking about people who use drugs because of the new opioid epidemic that's been happening in Baltimore for many reasons for a long time.
How are we doing as a society with these issues?
I mean, a society nationally, we have more people. The latest estimates for the 2017 estimates of fatal overdoses in the U.S. is up 13% from the year before, so it went from 59 to 72,000. Obviously, there's a lag in good programming and its impact on death, but I would say we have a long way to go because we, have an interesting conceptualization. Drug use is still seen as, in many places, as a moral failing, as opposed to the work that I do. I'm interested in, why and how. How is it? No one wakes up and wants to be running around, looking for drugs all day, but lots of people, if you it's like a bad social experiment. People grow up in neighborhoods where they don't see people walking home at 6 at night from work, that there are not a lot of jobs in the neighborhood, where there are high rates of violence in the neighborhood. I mean, drug use is like a very logical coping mechanism for a lot of people. And the work that I do is really interested in kind of the broader structural determinants that position people to make choices that sometimes are the best choices they can make, but aren't always the best choices in their health in a day-to-day way. So I would say we have a long way to go, besides embracing evidence-based interventions specifically around drug use.
What do these interventions look like?
Well, things like scaled up needle exchange programs that are best practices that operate, within communities at hours where people have access to them, meaning throughout the state. For example, there's a great syringe services program in Baltimore City that's run by the health department and that because of the new law, other organizations are going to be able to provide syringes. I found a drop-in center for women engaged in sex work, and we are hoping to have a syringe exchange there, so it would be for women only. A lot of different kinds of women go to that center, but it'll draw women who feel comfortable just going to a women's only space. So scaling up best practices, syringe services programs, drug checking. We know that so much of the market is adulterated. There's not a lot of consumer product information about illicit drugs, and so drug checking, which technologies we validated, tell people if fentanyl and its analogs are what is largely contaminating the drug market on the East Coast and responsible for such high rates of fatal overdoses in the last 8 years. And so in Europe, many cities have machines where people can check the full spectrum of drugs that are in, the substances that they're consuming, and that it's just basic public health. That likely is not happening tomorrow in the U.S., but that could potentially happen. It's happening in Canada.
Does it upset you to see people addicted to drugs everywhere?
I don't think people are addicted to drugs everywhere. I think that
I mean, it's hard. It's difficult to make it through the day in the Baltimore City without seeing somebody on drugs or in need of drugs.
I think, so there's been a fight to say that drug use is an addiction. I mean, problematic drug use, right? Or drug abuse, because all drug use is not problematic, is a public health problem, not a criminal justice problem. We've decided in this country that it's a criminal justice problem, so that we have people who've had small levels of marijuana who literally are, if they've had previous, like 3 strikes, you're out there in jail, in prison for a very long time, forever, for a really long time. So there's been, and under the Obama administration, there was a lot of adjudication for people who were released for low-level drug offenses. So public health, there's been a notion that drug use and drug abuse is more of a public health issue. But the problem, this is getting back to your question, when it's just viewed as a medical problem, a lot of what I view it, or as a brain disease, it kind of ignores the social context in which this happens. Like, yes, I think it's problematic that there's so many drugs in Baltimore City. I never thought I'd be working in another epidemic. I started in the AIDS epidemic in San Francisco and then moved to Baltimore and came here really to study and do work with people who use drugs. Who would have thought now there's this huge opioid epidemic where we have 1,300 people dying in the state a year of overdose deaths. But to me, what makes me sad is that I think of drug use as a social problem, but we don't look for social solutions like education, family reunification. People can't get jobs after they are released from prison. There are lots of reasons. It's very complicated social reasons why people use drugs. High rates of sexual and physical abuse of young, children. Broken up foster systems. So it's much easier to talk about it just as a brain disease instead of kind of turning the focus onto society that has all of these, like I said, bad social experiment. What's it like to have a neighborhood where people are, there aren't jobs available, schools, the tax base for schools are terrible, since that's the way we've decided we're going to fund our school systems, that schools are actually closed when it's hot because there's no air conditioning, and then you expect people to cope in life with lots of other things as well that happen. And so yes, it makes me sad to see that, but for lots of reasons, because I think that we've kind of failed socially to provide for people in a way that I feel that we should provide. And their brain, of course, their brain components as well of addiction, neurological components, but I think, we still haven't fully embraced the complexity of reasons of why people use drugs.
Thank you for helping frame that. I'm going to read the titles of two studies, and I just found them interesting. So the title of the first is Correlates of Exchange Sex Among a Population-Based Sample of Low-Income Women Who Have Heterosexual Sex in Baltimore, and Exploratory and Confirmatory Factor Analyses and Invariance Assessment of the Perceived Powerlessness Scale Among Youth in Baltimore. Can you talk about the powerlessness scale real quick and what that meant in your work, or how that?
Well, that was led by a student. That was a paper that came out recently that looked at. We did a study, kind of totally switching gears, of low and middle income, Black, white people, youth, 15 to 24-year-olds that were sampled from neighborhoods that were majority African American or white, low and middle income, to look at. The hypothesis was that risk behaviors were more associated with class than with race. And so one thing that we measured was this notion of powerlessness. And it was a scale that someone developed to how powerful or powerless people feel in their day-to-day life, and looked at how that was associated with sexual risk behaviors. Because, there's been a lot of writing about that people derive power from, telling someone that sex is complicated, sex has a lot of meaning, and so for some people, sexual relationships might be the only place where they derive power in their lives. And so this was trying to understand that relationship of a person's notion of their own kind of locus of control and sexual risky behaviors, and how that varied by gender,
Very interesting.
race, and class. Anyway, separate topic, but equally important.
And I like that topic.
How long does
Because of all the young mothers, and and then lack of the family structure that would allow people to grow up and know who they are and feel okay. So I don't know. I see that as a big deal.
What would you think? Well, Doc, what would you think would manifest the perpetuation of, using your analogy that you just gave me?
Yeah.
What do you think would be the larger influencers towards?
People are looking for identities, because we all crave. I mean, I'm a mother.
Yeah.
I waited a while to have that identity. It's an amazing identity. I can't imagine I don't know if it would be particularly empowering if I were 15, but I think if you're 15 and you may not feel like you have a lot of options, and someone says they love you, that might represent, but that, anyway, like I said, conjecture. But I would think for some people, motherhood is a great source of power, and for other people, sexuality is a source of power.
But which came first, the chicken or the egg?
I don't know.
That's a joke, right?
It's a good question.
I love
What
that.
studies are you working on right now?
We are
1,000.
a lot. We have this center in Southwest Baltimore, the Spark Center, which is a drop-in center with a range of services for women in Southwest Baltimore, and as well as outreach workers, women who have lived experience or close to lived experience around sex work and drug use, and we're evaluating the impact at a community level on those two components, on women's engagement in sexual risk, and also various drug risk behaviors. So the Spark Center, has showers, lockers, a place for people to hang out, watch TV, laundry.
Could you give the address of that location?
It's
Sparks?
908 Spark. It's 908 Washington Boulevard.
908.
And we also have medical. We have reproductive health on Mondays, buprenorphine, so people can get inducted for buprenorphine, which is in drug treatment, like methadone, Suboxone, and you can get that as opposed to at a methadone clinic. You can get it by a nurse practitioner or physician. We also have legal services on Wednesday nights. We have NA meetings. We're hoping to have a needle exchange, as I said. We have free clothing. We have food. We do lots of different things.
It's like an incubator for what works at all, or?
Well, hopefully it's an incubator
point,
for
good point.
women. So we've started to have monthly meetings for women that are, it's a very top-down approach. We've been working in Southwest Baltimore and Brooklyn and Cherry Hill for a long time through
God
our
is
studies
good.
with
God
sex
is good.
workers. And so we felt that there, and other places, and I've done study in exotic dance clubs in Baltimore. We felt like there weren't a lot of services for these women in this area. There aren't a lot of services specifically for sex workers in Baltimore City. The health department recently has been focusing, there's been a syphilis outbreak, so they've been focusing, going to a lot of the places where we go to do testing and treatment, which is great. We do testing and treatment. When I say where we go, through night outreach, day outreach, and also our study van does STI testing, and we make referrals for treatment. I think that the point, so as I was saying, it's a very top-down kind of approach to establish this center. And one of the goals of the study is to develop a sense of community and social cohesion so women can feel empowered to mobilize. So we've been there almost a year, like 10 months. And we now have, we have a lot more clients. Like, we steadily are seeing, last week we saw 50 women, which is really great. We're only open 4 days a week. We have more people coming to our monthly drop-in sessions for people to give feedback on our services. So the point is for people to feel ownership and also hopefully develop their own programs of things that they want. People from Street Outreach asked for yoga. We started having yoga. People came out of the shower, didn't have clothes. We started, we collected clothes. Yeah.
I want to go back to when you came in originally, and you were saying that one of the programs you guys initiated was the needle exchange program.
Didn't initiate it.
Or perpetuated it?
Helped to change the policy to make it more
a giveaway, more effective.
Not giveaway. Sorry, because
exchange. That was the terminology, huh?
It was a one-for-one exchange, and now it's needs-based. So if people come in and say what they need, and they don't have to put syringes on the table and have them counted.
I'm with you. And I like the way you gave me, because you gave me your geography. You say you come from San Francisco, then you went through North Carolina. And I was thinking about with the opioid problem, it's a bigger problem in West Virginia than it is in Baltimore. And that's a straight up redneck understanding, more Caucasian than black people.
For sure. The thing though about this, was there a question? Did you just want to comment on that, or did you want to ask something?
Towards that end. Now, what I want to say is that the needle exchange was basically to prevent AIDS perpetuation, right? As a result of people with initially, that was the infancy of it. Saying let's exchange needles, so you don't have to use someone's needle who already has AIDS, and you get AIDS as a result of a contaminated needle.
Right.
That's what. Go ahead.
Go.
I wanted to say too, what part of North Carolina did you come through? Because I'm from North Carolina.
Chapel Hill.
Okay, so Raleigh, Durham, Chapel Hill area, the belt. I got you. Thank you.
Yes, like West Virginia, which is incredible. I was in West Virginia talking around syringe services program a year ago, and the Macy's across the street from the hotel, someone had OD'd. Like the week before. It's a place where lots of people die in the libraries because they, and there's been this movement for librarians to get in the lock zone because people go and they use drugs, or they go to the bathroom in the library and they OD, right? Because it's a public safe bathroom. So there's been a great movement with librarians in places like West Virginia and elsewhere where people don't have access to, there are lots of unsafe places where people inject drugs. The thing about Baltimore, we've always had an endemic. First, heroin. Baltimore's been known as a heroin town since the 40s, 50s. Billie Holiday is kind of this example that often comes to mind of somebody that used drugs. Jazz in Baltimore. She was from Baltimore. And then, you have in the 80s.
I like this doctor here. I'm telling you something. I like you.
Thanks.
I really, really like you because I just figure out, I don't care whether you're Republican or independent. I like you. Go ahead.
I'm not a Republican or an independent. I have nothing against either, but anyway, Baltimore, in the 80s, jobs went away.
She's obviously not a Republican.
You never know.
Why you gonna
You're stereotyping.
I know. I'm not.
I'm not either.
Sorry, what were you saying?
I'm just saying that, like, no, we're not like West Virginia, but the root of what's happening in West Virginia, you know, you look to see, I mean, in West Virginia, the places where, and other places in Ohio and my home state of Kentucky, where the opioid epidemic has kind of raged in a way that it hadn't before, places where there are depressed economies. I mean, there are a lot of parallels. The timing is different.
I want to ask you a question, Doc.
Yeah.
Opioids are pharmaceuticals, right? Pharmaceuticals. They come from pharmacies.
Well, opiates are pharmaceutical.
Okay.
Opioids are heroin and
Yeah,
everything.
well, that's right.
Opiates.
Opiate is
Right.
heroin. Now, heroin is dope, right? So we talking about dope and pharmaceuticals. Now, I want to go back a little bit with you on the real. I would think that it wasn't the infancy of it because you go back to Billie Holiday, but the real perpetual stimulus of it was Vietnam War, returning Vietnam veterans. I knew more than one guy who came from Vietnam who was a user and held down a job at Bethlehem Steel,
Right.
General Motors.
So it's an interesting point, you know, yes, like methadone came to being in the US because in reaction to these guys coming home, and by the way, the policies on methadone have never changed in these clinics, like the federal policy about how methadone is dispersed since the Vietnam War. But interestingly, and I haven't read all of this literature, but guys came home from the Vietnam War and most of them stopped using heroin because they were given methadone, but also it was so context specific. And there are plenty of people, which is why I distinguish between people who use drugs and people who have problematic drug use. Of course there were people who used heroin, probably not every day, 10 times a day, and held down jobs and had mortgages and had their families intact. You start to take away some of those stability under their feet. Of course, like then, you know, it gets a little lopsided and people start using more.
I want to say something to you, Doc, because I like talking to you. Heroin, let's say, it's when the people who were using it, whether they're shooting, sipping, or whatever, they might do heroin one time, maybe twice. Where about base cocaine's usage was perpetual.
Well, it's different. It's like a different, you know, it has a longer, shorter half-life in your brain. I mean, cocaine, crack cocaine.
Correct.
You know, if everyone's...
I ain't talking about crack cocaine, because that's another devil. I'm talking about base cocaine.
Gotcha. Not free
Okay,
base
so
cocaine.
hey,
Okay.
now come
Well,
on there,
still
because
similar.
I know I'm talking to a doctor there, and I know you're a studier. I love you. I love you.
I'm not that kind of doctor, but I'm not a brain doctor.
Well, what I was saying to you, Doc, is that when it came to heroin, you know, somebody could take a shot of heroin and make it all day, especially if they wasn't really fanatical.
Right. So regardless if it's crack cocaine or base cocaine, it's the same. It's the same concept. It has a shorter half-life. You have to do it more. The high doesn't last as long.
I don't know that, but
People still do that, right?
Say it again?
Function. They function on they get drugs and go to work.
I'm gonna ask you
every
a
day,
question.
right?
You
It's
know the
same
number
thing.
one drug
Kind of,
out
yeah.
here is I'm thinking of Jesus, the antidepressant. Jesus, I get it for you. I can't think.
Xanax.
No, another one.
Well,
P. I'm thinking P. something.
Percocet?
No.
yeah, that's
It's for being hyperactive. What do the doctors give you?
Adderall?
No.
Adderall.
Jesus, I can't think.
What about it, though, Tim? What are you trying to say?
I'm saying that Prozac. That's what I'm trying to say. Thank you for that. Prozac. Prozac is
You
the
got
number.
it.
Prozac is the number one used opioid out here.
It's an opioid?
I mean drug, pharmaceutical prescribed meaning. Prozac. Basically, you know what it's supposed to do, right?
There's nothing wrong with drugs, then. Is that what you're trying to say? There's nothing wrong with doing drugs. It's not immoral.
I'm saying that the bottom line is all depends on. I'm gonna give you something else that I understand. It all depends on how they are prescribed. You know, I go see different specialists every day. This week I had because I gotta get things done. But I see different specialists every day. But I don't take anything. I take calcium and B12. You know, and he said that's what you need. That's
I was raised Christian Science, and we don't really
anything.
believe in taking drugs and stuff. So it's difficult. I mean, it's pretty old, really
Do
outdated.
you believe in
sorta
blood
thing.
transfusions? No.
Yeah.
You can't get a blood transfusion? I don't know. I just asked that question. Because you might be
But
a short time,
anyway.
and I want you to stay here a long while, Molly.
Dr. Sherman, thank you so much for talking with us today
Thanks for
about
having me.
everything you know.
Dr. Sherman, I want to ask her one more question before she go. What do you think about the, and this got to be promoted by your organization, I know you probably do. What do you think about the person, any person with a health insurance policy or a health insurance policy who got a pharmacy policy can go to any pharmacist, Rite Aid particularly, and get, I'm thinking about
Shot.
the Narcan.
Narcan.
Could you elaborate on that and what your
We
philosophy?
don't need to have. So Narcan is the drug that's used to reverse
Overdose.
an overdose.
Yes,
right?
ma'am.
So it
Yes,
literally
ma'am.
covers your receptor.
And they say
opioid
they said I could
receptors.
get it under my program for 50 cents.
Well, anybody can get it because the health commissioner, Lena Wen.
Now, how many people know this?
I don't know. It's a
This
good
is
question.
this is what I'm saying to you. Everybody know a darn junkie, and nobody know they can get something to save one.
And we don't really use that word anymore because it's.
Well, everybody know a user.
What it is, right.
I just said joke. Come on, What I'm saying when I say a junkie could be somebody on cigarettes, I suppose. Nicotine.
Yeah, but usually they're talking about junk, which is heroin. But it's fine. I'm just saying it's stigmatizing language, calling something.
Yeah, but I don't.
junkie.
I
Even though
don't.
I know people.
I
use
don't
drugs.
differentiate from heroin and freebase, and I don't differentiate. I mean, like, even if it comes to alcohol, it's no reason to
Stigmatizing them is not
differentiate.
going to keep them from
Yeah,
using.
and the stigma is just a subjective inference that has no degree of validity.
Well, it does if it keeps people from getting services or people feeling, because they feel like they're stigmatized because of the behavior. I mean,
I get you.
stigma
It might be
stigma
saying.
is real.
Yeah.
Yeah, and
But-
also people don't feel good about themselves. They may not expose what they do to their provider if they're going to the doctor. And anyway,
I got you.
all for another time.
Jesus. Thank you.
Thank you. Best wishes.
Thanks. You should cut that phone part.
Is that my phone?
No, his phone.